Okay, so chapter 24 is all about the management of the newborn at risk, considering the acquired and or congenital newborn conditions. Let's bring up the chat here. There we go. Okay. So our objectives, we're going to talk about acquired and congenital, and then the difference between the two. So with acquired disorders, these can typically occur either at birth or soon after, and it can be related to the labor progress or, process, or it could be something that's happened during the pregnancy itself, okay? Sometimes there's no identifiable cause for the disorder. For congenital, it's something related to inheritance, either genetics, as far as the fetal development process, during the growth and development, if there was a malformation or a sequencing issue with the DNA. So that's what congenital means. Congenital means that it was something done, it was already done in the formation of the fetal development. These are your typical, trisomies, things like that. Okay. So here's a list of all of the acquired conditions of the newborn, right? So the very first one, the neonatal asphyxia, this is the one that we're most worried about during labor and delivery, right? Because we want to make sure that that fetus is getting oxygenated, okay? Followed by transient tachypnea of the newborn, TTNB or TTN. And then respiratory distress. So these are related to the respiratory, remember, from intrauterine to extrauterine. They have to undergo that change to where they need to breathe on their own. The heart is shunting, closing the different ducts. So we want to make sure that that transition, that they're able to maintain their respiratory status. Meconium aspiration. So this is another one that we see a lot during post-dates or closer to term, 39, 40-week gestation. And also remember that if its meconium process is going on, the fetus is under some type of stress during the labor process, okay? Meconium aspiration is when they actually are taking that first breath and they're inhaling some of that meconium, okay? Persistent pulmonary hypertension of the newborn. So this is another one. It's not common. So this is something that is very one second. People are joining and exiting and joining. There we go. Okay, so persistent pulmonary hypertension in the newborn. This is something where you're going to see in the assessment of the newborn, they're going to have some respiratory distress, and it won't be right away, right? So building up that fluid and then the stress on the cardiac itself. Bronchopulmonary dysplasia or BPD. So this is something that you're going to see in like preterm, those infants that are getting mechanically ventilated for a long period of time. Retinopathy of prematurity or ROP. So these are your extremely preterm infants that have had oxygen therapy. So typical what you're being on the lookout for those NICU babies that are getting the oxygen therapy, because oxygen, if it's not titrated correctly, can cause damage to the blood vessels in the eye. The peri-intraventricular hemorrhage or PVH, IVH, again, your premature infants to where you're worried about bleeding on the brain, okay? Necrotizing enterocolitis or NEC. This is something also pretty common, used to be in the NICU, and they were tracing it back to either unsafe practices with hand washing, preparing formula, breast milk. There is evidence to show that infants that are fed formula are at an increased risk for necrotizing enterocolitis compared to those that are only receiving breast milk. With necrotizing enterocolitis, you're going to have a very distended kind of loopy stomach. They can have bloody stools, feeding intolerance. And oftentimes it's, if you do bowel rest, rest the stomach, make them NPO, antibiotics. It can kind of, if it's caught early, resolve on its own. For the more severe cases, they will have to have surgery because the bowel can actually become necrotic. Infants of diabetic mothers, we've talked about this in other chapters. So this is related to the pregnancy itself. Again, these are all acquired conditions. Birth trauma, so those are the ones that you'll see where they've had either a vacuum delivery and they've had the cephalohematoma. They can have a caput, kind of that molding. You can also have facial bruising for birth trauma. You can also have to where if they have had any type of clavicle injury, newborns of perinatal substance abusing mothers. Again, so it's something that was acquired during the pregnancy, related to the mother that will affect the fetus. Hyperbilirubinemia, we've talked about another chapter as well. And then newborn infections. So neonatal asphyxia, again, this is the one you're most worried about during L&D. You're wanting to make sure that that fetus is getting the, enough oxygenation, right? And that they're able to maintain that respiratory support after delivery. So the patho behind it is that insufficient oxygen delivery. Knowing the risk factors, newborn's color, notating their work of breathing, their heart rate. And remember APGAR scores. APGAR scores are telling us, what are APGAR scores telling us? Anybody know?
The adaptation of the baby to the external world.
Yep, their transition, right? So that can kind of give us a clue that maybe they may have some difficulty, right? Need some extra support. So your nursing management, whether need resuscitation at birth, making sure that you're doing that continued observation, that neutral thermal environment, right? We want to make sure that they're not getting cold stressed, right? Because we know that if they're cold, they're going to increase their oxygen demand, increase their glucose demand, right? TTNB. So this is a mild respiratory distress. Pulmonary liquid, remember in utero, they're breathing in, I say breathing loosely, but their amniotic fluid is what is running through their lungs, basically. So when they are born, sometimes that retained fluid can cause TTNB. Babies born via C-section are at an increased risk because they're not getting that nice squeeze, right, from a vaginal delivery. So your nursing assessment, your newborn, you may see that they may have tachypnea, they may have expiratory grunting, some retractions, again, labored breathing, nasal flaring, some mild cyanosis. Typically, the respiratory rates are going to be greater than 100, probably close to like 120, 130, a barrel-shaped chest, and then their breath sounds will be slightly decreased. On X-ray, the classic sign on X-ray is the prominent perihilar interstitial marks and streaks, okay? So making sure as far as nursing wise, we're gonna make sure that the newborn's gonna get the oxygen that they need, supportive care, IV fluids, and gavage feedings. This is important because if they're struggling to maintain their respiratory status, we don't want to overstress them by trying to feed them, right? So we want to let them rest. Respiratory is more important at this point. So we can start an IV. We can give them gavage feedings, okay? And then again, maintaining that nice neutral thermal environment. So true or false, neonatal asphyxia commonly resolves within 72 hours after birth.
True. If that's the one we were just talking about, then yes. The TT, whatever, then it's true.
Neonatal asphyxia.
I don't know.
False. Neonatal asphyxia requires immediate resuscitation, right? So this is what's happening at birth. Transit tachypnea of the newborn typically resolves on its own by 72 hours of age. Okay. Respiratory distress. So this is the most common NICU admission diagnosis. A lot of the times it's due to lung immaturity or the lack of the alveolar surfactant that's helping those lungs from collapsing and sticking together. Some risk factors, right? Again, prematurity, if mom is a diabetic, things like that will actually increase RDS. Okay, expiratory grunting is what you'll see with some nasal flaring, chest wall retractions, possible seesaw respirations, generalized cyanosis, and the newborn's heart rate will be higher than 150, so 150 to 180. They can also have fine inspiratory crackles. And then tachypnea, Silberman-Anderson index score will be greater than 7. So I've never heard anybody in the NICU call it the Silberman-Anderson index score. However, on the next slide, you'll see how the score is assigned, and every NICU nurse, any postpartum nurse, L&D nurse, they're assessing this, but they're not actually giving it a number, right? On X-ray, you'll see hypoaeration of the lungs, under expansion, and then ground glass pattern. So the Silberman-Anderson score, so this is how it's scored. And when you're assessing the newborn, you're looking at the chest movement, intercostal retractions, if there's a xiphoid retraction, are the nares dilated, are they having expiratory grunting? So as nurses, when we're assessing newborns, we're looking at all these different aspects of the assessment. However, we're not actually giving them a score of 0, 1, 2, 3, right? We're just assessing and noting on our assessment what we're seeing or relaying that to the provider. But it's included in the lecture because your textbook mentions it. So, and you might see it on PrepU. I will not ask you to score using the Anderson. I will not ask you to provide a score on the test. Respiratory distress, right? So the nursing management for that is supportive care, whether it be, you know, again, and it's going to be a NICU admission. And so supporting the parents and providing the education as far as maybe the possibilities of why the newborn needs the oxygenation support. It can be ventilation. So it can be the newborn can be on a ventilator and or a high frequency oscillating vent, which is the most, the highest level of support. Typically for RDS, they come back on CPAP, which is a continuous pressure support. Sometimes they get surfactant or CuraSurf in the NICU, depending on the circumstances surrounding the RDS. We can do cultures and labs and then possibly start on antibiotics. So who can provide me an example of a newborn that has RDS that would need antibiotics?
If they have pneumonia.
Oh, there's 2 answers there. Try again. I heard you both talk at the same time.
I was
Or
saying
what did you say?
the
Okay.
GPS positive baby.
Okay, but not all GBS positive mothers that are untreated. Not all babies have RDS. But yes, they would maybe need antibiotic prophylactically, right? What's the reason why a newborn would have RDS and then also need antibiotics?
Say the baby's post.
Respiratory pneumonia, aspiration pneumonia,
Okay, yeah, meconium.
and the meconium.
Okay, meconium aspiration. Think about membranes.
If they have TB.
Oh,
Ruptured membranes,
what about the ruptured membranes?
cause for infection.
Too
Okay.
soon. It's been longer than 24 hours since their thing ruptured, and now they're exposed to all kinds of stuff. So they would prophylactically give antibiotics.
Yeah, so those newborns whose mothers membranes have been ruptured for more than 18 hours or so are at increased risk for respiratory distress and or infection. So if they have a respiratory distress, they will prophylactically start antibiotics after they draw the blood culture, and wait about 3-day wait time for the culture to come back. But they don't want to delay antibiotic therapy. So having prolonged rupture of membranes increases the risk for RDS and the need for antibiotic use in the NICU. We can also provide fluids and vasopressors. Again, if the newborn's having any type of respiratory distress, we're not going to start PO feeding right away, right? We're going to do gavage feedings and IV fluids, okay? Monitoring the blood glucose levels, clustering care. We're going to try to do everything. We don't want to go in every hour and disrupt or disturb the newborn. We're going to keep them kind of prone or sideline if possible. And then again, making sure that their temperature is stable and they're in that neutral thermal environment. So meconium aspiration. So this is where they're inhaling that meconium particulate, and then with also amniotic fluid. It's secondary to that hypoxic stress. You will see newborns, they may have staining of the amniotic fluid, right? So you'll see when the membranes rupture, it can kind of be green, it can be thin, it could be thick like pea soup. You may see some staining on the newborn's nails, their skin, the umbilical cord. They will typically appear with that barrel-shaped chest. They can have prolonged tachypnea, increased respiratory distress, intercostal retractions, and expiratory grunting, cyanosis. Their lungs on auscultation will be very coarse crackles. On the x-ray, what you'll see is a patchy, fluffy infiltrate, hyperaeration with some atelectasis. And then they'll definitely have an arterial blood gas or capillary blood gas. And then you'll typically see these newborns will show as metabolic acidosis on the blood gas. So again, if they have any type of meconium at delivery, we want to make sure that we're suctioning at birth. We want to make sure that we're helping expel as much meconium that we can. We want to make sure that newborns are getting the adequate tissue perfusion that they need. So a decrease in oxygen demand and energy expenditure. So if we've done everything, we've done suctioning, we've provided oxygen support, ECMO, if all other interventions fail. So ECMO is not done anywhere in Bakersfield. Typically, they're sent either to LA or to Madera Valley Children's. And it's very rare, and it all depends on the gestational age as far as when this treatment, if it's a possibility. So what it is similar to the heart and lung bypass that they use for open heart surgery. And what it does, it allows the body to rest, the heart and lungs to rest while it pumps and oxygenates the newborn's blood outside of the body. Okay. Again, making sure that they have a neutral thermal environment, and then providing support and education to the parents. And ECMO is last resort. It's not very common, but for meconium aspiration, again, letting that heart and lungs rest while still maintaining oxygenation. PPHN, so this is marked pulmonary hypertension. It's causing right to left extrapulmonary shunting and hypoxia. So what you may see in the newborn is within about 12 hours after birth, they'll have tachypnea, they'll have marked cyanosis, they'll be grunting and having some retractions. So if you remember back to, I think it was chapter 17, the newborn assessment, I believe, when she was listening to all parts of the heart, you will hear a systolic ejection murmur. So that's why it's very important that when you're assessing, that you're listening to all the points of the cardiac. For these type of babies, if you hear a murmur, again, you'll pass it on to the pediatrician in postpartum, and they can order an echo. And you'll see in the echo a right to left shunting of blood. So monitoring oxygenation, perfusion, blood pressure also, oxygen therapy, respiratory support, medications. Anybody know what medication they give for PPHN? I'll take the generic name or the trade name, brand name. One starts with an S, one starts with a V. Sildenafil or Viagra is what they'll give for PPHN. Okay, and again, we're going to cluster the care. Any newborn having any type of respiratory issues, we'll cluster the care, meaning we'll go in and do our assessment, vitals, diaper change, all at once. We're not going to go in every hour, 1 hour do a diaper change, 1 hour do an assessment.
What did you say? Viagra?
Mhm.
Viagra. Okay.
So, true or false? The underlying problem associated with meconium aspiration syndrome in utero involves hypoxic stress.
True.
Yes, this is true. So BPD or CLD, so these are typically the newborns in the NICU that have had oxygenation support for more than 28 days after their day of life. And it can be related to prematurity, surfactant deficiency, pulmonary edema. Sometimes it's barotrauma from being on a mechanical ventilator. So mechanical ventilation has also been associated with an increased risk for BPD and chronic lung disease. So when you're assessing the newborn, right, you're always going to look at the x-ray, the most recent x-ray, especially if they're on a ventilator, because you want to see the lung expansion. You will count each rib, right, on the x-ray to see how much they're expanded. Administration of steroids in the mother, again, betamethasone ×2. And then we can also give surfactant or we use Curosurf at our hospital to the newborn after delivery. So your assessment, so the history for risk factors, right? So if it's a male infant, if it's preterm, less than 32 weeks, if they are of white race, if they have a PDA, severe RDS, if they've had severe RDS and been on a ventilator for more than 1 week, or if they've had any type of infection. You can see tachypnea, poor weight gain, tachycardia, they'll have sternal retractions, some nasal flaring. You also can hear some crackles or wheezing. Typically, the blood gases will be consistently, will show hypoxia. So again, continuous ventilation, oxygen support, making sure that they're getting enough nutrition. They can administer bronchodilators, anti-inflammatory agents, and diuretics as needed. Always monitoring the newborn's respiratory status, providing a high-calorie diet, and then educating the parents and family about ongoing care if needed. Again, so they've typically been on oxygen support, ventilation support for an extended period of time. So it may take a little bit longer also to wean them off if they're ever able to be weaned off that ventilation support. ROP is, again, more towards the premature infants, right? And it's, I'm not going to ask about all the different stages and zones, but know that as it advances, it can go from very mild case of ROP to very severe to where it can cause blindness. Some of the milder cases, they can do laser surgery at the bedside. They can do injections into the eye with a medication. It's a chemotoxic agent that they use. So, making sure that, again, that they're getting the oxygen support that they need, but making sure that it's also being titrated appropriately. And it can happen typically in both eyes, because again, if they're getting oxygen, it's going to affect both blood vessels of both eyes. And it's due to hyperoxemia, right? Because of assisted ventilation and high oxygen exposure, it can either be related to acidosis and or shock. So typically immature newborns will be set to have an ROP exam and eye exam, and then it'll be followed every typically every week or every 2 weeks, depending on what the images show. And then it can also lead later in life to where they would the child would need glasses and or corrective surgery on their eyes. Prenatal history, right? Hypertension, if they've been a substance abuser, preeclampsia, if they've smoked during their pregnancy, or if there's any type of placenta insufficiency. So newborn gestational age and weight. So those newborns weighing less than 1,500 grams, or they're born at less than 28 weeks or less, are at greatest risk. Again, always assessing, evaluating the newborn's history, duration of the intubation, and oxygen therapy. Making sure the oxygen is being administered cautiously. And when I say that, it's so oxygen therapy can be delivered at different, I guess, richness of FiO2. So room air, which is what we're all breathing right now, hopefully, is about 21% FiO2. So what we do is we titrate the FiO2 for the oxygen that the newborn's receiving. So sometimes they may need like a 30% FiO2 just to maintain their oxygen saturations. We don't want them to be satting 100% SpO2 and then their FiO2 be at 30%, right? Because that means that they're getting more FiO2 than what they're actually needing. So we want to adjust it and titrate it and give them the least amount of FiO2 that they need to maintain their oxygenation. Protecting the newborn's eyes from light. Typically the eye exams for ROP, they will dilate the eyes, and then they'll also provide a type of numbing eye drop so they can use the tools to open the eyes to get a better image. Making sure that the parents are given information about the details of any condition, right, of ROP, and then the need for follow-up eye exams. PBH, IBH, again, this is the most common in those extra low birth weight infants, very premature. So it's most commonly seen in the first 72 hours after birth, and IBH is graded from 1 to 5. So in our NICU, we've implemented the golden hours IBH protocol to where we do not weigh a newborn less than 30 weeks for the first 72 hours after their birth. So we won't pick them up, we won't weigh them. We keep them in a midline position. So their toes, their nose, shoulders, hips, legs, everything is nice and midline for 72 hours to help prevent IBH. So there could be possibly no symptoms, right, of IBH. Typically they will have a drop in their hematocrit because IBH is bleeding, hemorrhaging of the brain somewhere. They can have poor perfusion, they may have seizures. Typically it's a weak suck, high pitched cry. So if it's a 26 weeker, 27 weeker, they're not going to be crying because they will probably be most likely be on the ventilator. But you may see hypotonia. They'll do a head ultrasound and take images, and that's where they'll be able to see if there's any hemorrhaging. And that's how they'll grade it, depending on the area of the brain, how much is covering. And then with IBH, those the hemorrhaging on the brain can lead to cyst formation, which is further complications down the road as far as cognitive and learning and intellectual disabilities. So prevention is the number one. There was a delivery that I attended with another NICU nurse probably 4 years ago, and it was a C-section, and it was a 25-weeker. The OB provider literally pulled the neonate out and by their feet and held them upside down, right? So all the blood is rushing to their head. So that neonate did have an IVH, so it's completely preventable, right? That may be okay to pull a term newborn out like that, not really, but if they need to, but definitely not a preterm newborn. correction of any anemia, acidosis, and hypotension, making sure that they're in that flexed, contained midline position, monitoring the daily head circumferences, clustering of care, limiting any type of stimulation, and then providing that support to the parents, just because if there is a diagnosis of IVH, they'll have typically the first ultrasound, head ultrasound done is day of life 3 and 10. Sometimes if they're concerned about an IVH right away, they'll do it on day of life 1. But there might be some long-term repercussions of the IVH later in life. Sometimes they can resolve all on their own as well too.
So in that situation, when you're watching this doctor do that, do you say anything? Do you, not at that time, but like, is it your guys' responsibility to say something to like be the charge nurse, or like if he caused that baby's bleeding in the brain, then
right.
what do you do about that?
Yeah, so it's every facility has their own way of reporting certain events and things like that. So what we did was that, because we both witnessed it, she was the charge and I was her backup. Of course, we're not going to say anything right there in that moment because there was other pressing things going on. But we reported it through our radar system. And then that gets channeled to our manager, the L&D manager, director, because we list the provider and then who all was there, who all witnessed it, who all with the care. And then she also went, after we were stabilizing the baby, she went and talked to that provider as well. And she just said, her conversation with him was probably very professional, but there's no doubt in our mind that, that it was probably likely caused by that. However, when they're that premature, you can't really pinpoint because they're at the most increased risk for it. But had he not done that, the baby still could have had an IVH, right? Just because of the gestational age. But it's something that, you hope that by, reporting it, that they're more aware.
Yeah.
Time to prevent it. Mm-hmm. Yeah, so every facility has their own process to report things. Even if it, something it's a near miss or it is a miss, like it could be a medication error, like anything that can impact patient safety, or if there's a workaround or a process that needs to be re-examined. Every facility has their own, I guess, internal reporting system. That way, because if I see something that somebody does and I say, oh, I don't maybe think that's correct, right? If I don't say something, it's going to continue to go on, right? And it may be that that person isn't aware that there's a new way to do things, right? So always don't ever be afraid as nurses, even new grads, when you're out on the floor or even as nursing students, to kind of question things, right? Because if you see something or you feel that something's not right, it's okay to ask somebody and then, to question it. But there's a professional way to do it too, right? And there's a time and a place, and in the middle of the OR to say something to that OB provider is not the right time and place, right? But making sure that we both follow through and reporting and, the conversation that she had with that provider. Because if you don't know, you don't know, right? So we're all nurses, we're all there, helping the patients. We all need to educate each other and our colleagues. Necrotizing enterocolitis. So this one, again, like I mentioned before, evidence has shown that those newborns who have been feeding formula, and these are more the preterm, very preterm infants, right? Newborns that only get formula, it's not that big of a risk but these are more the preterm infants. It causes bowel ischemia, bacterial flora, and then the effects of the feeding, right? So you have to have all three, but typically feeding intolerance is going to be one of the first ones, but the descendant abdomen, very loopy. And when I say loopy, you'll see this almost like little bubbles in the stomach. Sometimes it looks like they have like a 24 pack of abs in their little tiny bellies, because they're just so defined ridges. They can be hard, they can be soft. So again, the abdominal distension, tenderness, bloody stools is more of a later sign. The feeding intolerance is the most common first sign of possibility of neck, and then sepsis and lethargy, apnea, and shock. So on an x-ray, so KUB, you can see air in the bowel wall. The bowel loops will be very dilated. Predisposing factors, right? Here's the prenatal factors and then postnatal factors. Again, typically the premature infants, those who are not receiving strictly breast milk, Bakersfield is very fortunate that all hospitals in Bakersfield offer breast milk, donor milk to all of at least all of the premature infants in the NICU. Some hospitals do breast milk donation for postpartum babies, but all the NICUs in town, they use donor milk if breast milk is not available from the mother for the NICU babies. So that actually will help decrease the risk for developing neck. But these are your risk factors for prenatal and postnatal. Maintaining fluid and nutritional status. Again, they're going to do bowel rest, so they'll make the baby NPO, start them on antibiotic therapies to kind of help see if that will relieve the abdominal distension, loops. Sometimes they can give suppositories that kind of help move everything through. And then for those most severe cases, or if there's any type of necrotic bowel, they'll do surgery. So if you're the nurse, what can you expect to assess in a newborn with necrotizing enterocolitis?
C.
Abdominal distension. Yes. Abdominal distension, bloody stools, feeding intolerance. Okay. So infants of diabetic mothers. Again, we've talked about this a little bit in other chapters. High levels of maternal glucose is crossing the placenta. It stimulates the increased fetal insulin production, leading to somatic fetal growth. So infant will have full rosy cheeks, kind of ruddy skin color, a very short neck, can also have a buffalo hump on the back of the neck. They'll have massive shoulders, distended upper abdomen. They'll have excessive subcutaneous fat tissue. They could experience hypoglycemia and/or birth trauma.
This is a mom with very poorly treated diabetes during pregnancy, right? Not one that's got controlled.
Right. So
Okay.
if they are, if it's poorly controlled or poorly mismanaged or, non-compliant, you'll see
The baby's going to be a mess. Yeah. Okay.
However, they can have control, right, of their glucose, and they can be doing everything correctly. Like, they're checking the blood sugar, they're doing their nutrition. It doesn't mean that the baby is going to come out just like this. They may be of a higher birth weight, right? But they're not going to be to this extent.
Okay.
And diabetes itself also poses other risk factors to the newborn, even if it is controlled, because of the pathophysiology behind it. But it's your typical poorly controlled, undiagnosed diabetic mothers, to where you'll see this type of assessment on the newborn, and/or renal abnormalities, cardiac abnormalities, that type of thing. So this is your poorly controlled diabetic mother here.
Okay.
The infant could have hypocalcemia, hypomagnesemia, polycythemia, and hyperbilirubinemia. And once you see one newborn of a poorly controlled diabetic mother, they all look the same. It's a very distinct characteristic assessment. Almost you can pinpoint it right away. So what are we going to do as nurses? We want to prevent that hypoglycemia. So starting feedings early. If we need to supplement with formula with the breast milk, we can do that as well. Making sure that they have that nice thermal environment that's neutral, because we know that cold stress increases oxygen demands and increases glucose consumption. Making sure that they're resting. So if a baby is consistently crying and upset, they're using that energy, right? They're using their glucose. We want to monitor calcium levels. We can start IV fluid therapy if needed, and then check. All newborns have bilirubin level checks at 12 hours and 24 hours of life, but we want to make sure that we're also monitoring that as well. And then providing support and education to the parents. Typically, the infants of diabetic mothers, to where it's poorly controlled, right? The newborns are poor feeders, right? They're so hungry, so hungry. They can't figure out how to eat. So they, if you're trying to give them a bottle of formula, they don't know how to suck on it. They chew it. They're very just poor feeders. So it takes a lot of work with them to get them to the point to where they're able to eat. So typically if they're in the NICU related to severe hypoglycemia and poor feeding, typically they're there for 1 to 2 weeks, depending on how soon we can get their glucose to be stabilized and off the IV fluids, right? We can also do gavage feedings, if we're worried that, the IV's been in too long, or, they're tolerating the volume of the feedings. So we can remove the IV fluid and gavage feed it until they learn how to eat by the bottle. Substance abuse, abusing mothers. We talked about this, I think, last week a little bit. So the most common substances are tobacco, alcohol, and marijuana. We talked a little bit about fetal alcohol syndrome, neonatal abstinence syndrome. So the drug dependency, it's acquired in utero. Again, they'll have that neurological and physical behaviors at birth, sometimes depending on when the exposure happened and how recently the mother used is when you'll see symptoms or, displayed behaviors in the newborn. Sometimes it's as quick as right at delivery. Sometimes, it takes up to that first 12 hours. So I'm not sure on other facilities in town, but typically with NAS babies, you have a positive drug screen from mom, you need to start scoring these neonates within the first 2 hours, right? For the first 12 hours of life. That way you can see, because a lot of the times we'll hear, oh, the baby was withdrawing in postpartum. They bring him to NICU and you're like, oh, okay, what was the score? Well, nobody was scoring the baby, so there's nothing to base it. Is it getting worse? Is it getting better? Also keep in mind that marijuana has not been shown to have teratogenic effects on the fetus. Alcohol, nicotine, and cocaine do affect the fetus. What we see in mothers who use marijuana, sometimes in the newborn, they can have no symptoms after delivery. Sometimes if they're continuing to breastfeed, which is up to the pediatrician, sometimes they say, yes, go ahead and breastfeed. Again, it's a controversial issue because it's not recommended to breastfeed while smoking marijuana or ingesting marijuana, because marijuana likes to attach itself to the fat in the breast milk, right? And so they're getting large doses of, that substance in the breast milk. So it's up to the pediatrician and that family. But again, it's not really recommended for the mother to smoke marijuana and breastfeed. Maternal history, we want to know
real quick, what score? What are they scoring? What score is it again?
So there's a withdrawal assessment on box 24.4.
Oh, okay.
And then what we use at our facility in our NICU is the Finnegan scoring. And I think most hospitals in Bakersfield use Finnegan scoring. And it's based on, do they have a high-pitched cry? Do they sneeze? Are they having tremors? Are they inconsolable? How many hours are they able to sleep? Do they have, typically NAS babies will have a severe diaper rash, excoriation, things like that. So it depends on the facility. Your book mentions the withdrawal score assessment, box 24.4. But again, you'll see those behaviors when they're withdrawing. I think it was similar to the video that I showed last week. It can be very extreme to where they are continuously shaking and can't stop. It could just be that they're kind of stuffy nose, sneezy. It all varies. Again, it depends on what the substance was, when the last exposure was, how often they used it during pregnancy. So reducing stimuli. So the best evidence-based practice is eat, sleep, and console for these newborns. And, you know, making sure that they're eating, you're consoling them, and that they're getting as much sleep as they can, which means turning down the lights, making sure that there's not a lot of noise, right? And so this takes a lot of work and dedication from the parents, if, you know, to help prevent a NICU admission and or using short-acting or long-acting drug therapy, right? So depending on what the substance is, the score or the withdrawal assessment of the newborn, it may be that they need additional drug therapy to kind of help ease those symptoms. But we always want to make sure that you're doing what you can first non-pharmacologically, right? Because we want to make sure that we've exhausted that option before we start any type of drug therapy. Making sure that they're getting the correct nutrition. So I think I mentioned this last week, but mothers who are going to they're going to the clinic, right? And they're getting
Methadone.
Methadone,
Yeah.
They're getting medication to help with their addiction, right? So I know one neonatologist will be like, if mom's getting treated, it's passing through the breast milk, it's going to help the baby. So that little bit, it's very, very, very small, but that little bit can actually help deter them from being admitted to the NICU, to getting morphine or anything, or fentanyl, you know, any type of short or long acting drug therapy. Always preventing complications, right? So there could be some neurological complications. Again, that extreme excoriation of the bottom. So making sure that they have Desitin or Bordeaux's butt paste. Making sure that you're observing the parent and newborn interaction, right? Again, everything's happening right after birth. So there's lots of emotion from the mother standpoint. There may be some guilt, right? Family members may not know that there was an issue during the pregnancy. So always making sure that as nurses, we're observing the entire surroundings and interaction from all parties with the newborn. So birth trauma. So this is just related to any injury due to the force of labor and birth. It can range all the way from fractures to brachial plexus nerve injury, cranial nerve trauma, head trauma, cephalhematoma, caput. Which one crosses a suture line, caput or cephalhematoma?
Kappa.
The cap, yeah.
Okay, great. You can see the picture over here to the right. It looks like there's some facial bruising. So my stepdaughter had her baby on Tuesday this last week, and she has facial bruising. So she looks kind of very similar. It's actually a lot better now that she's a week old, but it looks very similar to that.
Because they used a tool, or just because the squeezing?
Yeah, it could be either or, right?
Oh.
So this could be just by it could be like a facial presentation during labor. It could be, you know, precipitous labor. It could be very fast, you know, depending how long they were pushing. It could be a little bit, you know, it's all dependent on just the labor itself. So not only is it a mechanical tool assisted labor, this could just happen on its own as well. Typically, the fracture and brachial plexus injury are going to be those ones that are descending down. They're ready to deliver, right? And either they are stuck behind the pelvis, right? Like a shoulder dystocia. and that's the typical where you'll see like the clavicle fracture. The brachial plexus injury is where, you know, the provider is helping assist and pull, and it can kind of stretch the shoulder here. Knowing the risk factors, physical, neurological assessments, if there's any bruising, bumps, swelling, paralysis, always looking at the symmetry of the structure and function. An injury to the upper brachial plexus or Erb's palsy is manifested by adduction, pronation, and internal rotation of the affected extremity. Absent shoulder movement, absent maral reflex on the affected side, and a positive grasp reflex. So if you look at this image, so you can kind of see here how the right arm and hand is being raised, and this left arm and hand is flat. They're still moving this right side, still moving the right side, but the left side is not moving at all. Okay, so depending on the injury itself, it can resolve on its own, or it could be to the extent where the nerve never recovers, and then they lose all function on that side. Newborns and into toddler, you know, childhood, they can do physical therapy to try to help the situation. But a lot of the times, not a lot of the times, most of the ones that I've seen have been not so severe to where by the time that they left the NICU, they had movement of that affected side. Sometimes they'll say it's like almost like a waiter's tip. So like sometimes they can have one go this way and like one go this way with their hands. So always offering support to the family, doing your assessments, see if anything is resolving or if there's further complications, realistic appraisal of the situation, community referral for ongoing follow-up and care if needed, depending on the type of trauma. For any type of clavicle fracture, there's not really a lot that can be done for a clavicle fracture. They're not going to put it in a cast. But what they could do is try to keep this arm kind of like stabilized and close to the body. So they may just do like a band across. They may just kind of keep it swaddled and just try to prevent, you know, movement of that side, and just let the clavicle heal on its own. Hyperbilirubinemia, I know we've talked about this in other chapters. So again, it has to do with imbalance of the rate of bilirubin production and elimination. So physiological again is 3rd to 4th day of life. Early onset breastfeeding could be also late onset breastfeeding. Pathological again happens within the first 24 hours of life. It can result in kernicterus, which kernicterus is something that it was common probably, oh my gosh, probably 30 years ago, right? I don't think it's 2023. So a long time ago, they would look at babies and be like, oh yeah, you look okay, and send them home, right? They would never check for bilirubin. They would just do a visual check and say, oh, you don't look yellow, you can go home, or oh, you look a little yellow, put them in front of the window, right? What was happening was that the jaundice levels was so high that it was causing irreversible severe brain damage, kernicterus. So now it's, you know, they've implemented, you know, checking Billy, you know, 12 hours, 24 hours, again, at the follow-up after discharge for the newborn. And like very extreme cases, they can do, let me go to the next slide. In very extreme cases, they can do exchange transfusions. As far as I know, it's very, very rare. And people that I've talked to that have been nurses for 20, 30 years, most of them have never seen it in their practice. Maybe one of them has in the last 20 years, but it's very, very rare to do an exchange transfusion, meaning that they're exchanging all of the blood in the newborn with new blood, right? This is a very all hands on deck. It's a 4-to-1 nurse to patient ratio, and it's 2 physicians at the bedside during the entire exchange transfusion. typically with hyperbilirubinemia, we can increase the feedings, right? We can start phototherapy if needed. Okay, so typically things like that will actually help with the jaundice. But phototherapy does is it's that blue phototherapy light, and it emits a wavelength. And what that wavelength does is it shakes that bilirubin and it makes it water soluble. So that allows the newborn to excrete it mainly through the stool and through the urine, but most of the bilirubin will be excreted through the stool. Let's see, there's a comparison chart 24.1 for bilirubin levels, providing education. Home phototherapy is not as common as at least from what I've seen in Bakersfield. Normally, if there's phototherapy, they'll do it, you know, in pediatrics or in NICU, depending on the level that's needed. There's a link here called billytool.org, and I'll take you there in just a second, but you can see the different types of therapy. So this is just like a wrap that goes around the chest. But keep in mind, the phototherapy is only going to work where it's this is able to emit the light to the skin. So this is only working across the chest. This one here, the eyes and genitalia, that's the important thing, is to make sure that those are covered at all times during phototherapy. But you can see the blue light is from head to toe. The same here, and then this one here, it's only pinpointing the stomach and chest area. A lot of the times, phototherapy, evidence-based practice has shown that you want to get phototherapy from multiple levels, right? So this infant here is laying on looks like a Billy blanket, and then there's an overhead phototherapy light. So from top and then from the backside as well. But this one here, keep in mind for safety, if they're under phototherapy, they should have eye protection on. Let me see if I can click this here. So this is, I'm going to take you to, so this is, can you see the Billy tool that I pulled up? Yeah. So this is something that's used in assessing whether or not to start phototherapy. So let's say we're taking care of a patient that was born yesterday at noon. And today, what time is it? We'll say we just drew this specimen now. Okay, let's say the bilirubin was 7, and this is a term kiddo, we'll say 38 weeks, and there's no other neurotoxicity risk factors. So it will give us, we took the sample at 22 hours. It was a TCB, meaning it's the one that's transcutaneous, so it was not a blood draw. It'll tell us, do we need to confirm with the total serum Billy? No, because the threshold is 9, and we came in at 7. Do we need to start phototherapy? No, the threshold is 11.9. Okay, so it'll give information as far as the recommended part of the treatment, and it all depends on gestational age, neurotoxicity risk factors, the exchange transfusion. So for this newborn, 22 hours of life, 38 weeker, the Billy would need to be over 21 in order to do exchange transfusion. Typically, you'll catch it before it hits 21 and start phototherapy, and then do a serial monitoring of total TSB. And then if it starts to creep up that high again, they would consider the exchange transfusion. Okay. Go back. Oh, let me go down really quick. So this, you might see that, or you might see the graph in a clinical setting. So it's the same concept. You would go to the newborn hours of age. So that newborn was right around 22 hours. And then the Billy was 7. So this will tell you, again, do we need to start phototherapy, escalate the care, or more extreme exchange transfusion? Okay. So if it's, let's say the baby was 12 hours of life, and it was maybe right up here around 7, let's say 8 or 9, they may say, okay, we check it again in 8 hours, you know, and see where it falls. Okay. Neonatal sepsis. So this is another type of acquired, right? So it could be bacterial, fungal. Manifestations of sepsis are typically non-specific and can include hypothermia, so or temperature instability, oliguria or anuria, lack of interest in feeding, and lethargy. So it can be congenital, so it means that it was acquired in intrauterine, early onset, so right after delivery and the perinatal period, or late onset. Really, just knowing that hypothermia, lack of interest in feeding, and lethargy are the most common signs and symptoms. And typically you'll have the provider will order blood culture and C-reactive protein. The blood culture will come back positive and tell you the organism that's causing the sepsis. They'll be starting on antibiotic therapy prophylactically until the culture comes back with the organism identified, and then making sure that the correct antibiotic is being administered to treat that organism, maintaining their circulatory and respiratory support, nutrition, and then depending on what is causing the sepsis, education, and then primary disease prevention. For congenital heart disease, just knowing that there's different ones, right? And that the heart disease can be congenital, can be related to increased pulmonary blood flow. It can be obstruction of the blood flow out of the heart, so aortic stenosis, tetralogy of Fallot, which means it's causing a decrease in blood flow. And that there's also desaturated or saturated blood mixing is another type of defect. Depending on what type of defect they have, they could be nice and pink. They could be cyanotic and then they cry and they turn pink. They can have cyanotic all the time, cyanosis all the time. So just knowing that there's different types, I'm not going to be very specific on for testing purposes, but knowing that that's why you do your newborn assessment and you listen to all parts of the heart. It can be related to maternal factors, right? Alcoholism, diabetes. It can be a single gene mutation or chromosomal disorder. If the mom was exposed to x-rays during pregnancy, if they had a rubella infection, or if they just had poor maternal nutrition. If they're over the age of 40, if they use amphetamines, it could be a genetic factor. It could be something that's a family history of cardiac congenital heart disease issues. It can be a metabolic disorder of phenylketonuria. If they've used any anticonvulsants during pregnancy, estrogen, progesterone, lithium, warfarin, or isotretinoin, which is actually a tetragonic agent. So all just kind of depends on what happened during the pregnancy, anything that they've taken additionally. So assisting as nurses with blood gases, x-rays, they may have an MRI, they'll probably have an echo. Continuous monitoring, we're going to do cardiac monitoring, administer medications if needed. Sometimes they may need a medication to help keep their ductus arteriosus open, right? So after delivery, we expect that to close. So there are some cardiac conditions where we need that to stay open for the heart to pump as needed for that patient. So we can give medications such as PGE to help keep that open. The congenital conditions, so really the ones that are bolded, the neural tube defects, right? We know that's can be related to a lack of folic acid intake. Cleft lip and palate. Sometimes if they are substance abuse during pregnancy can cause that. Sometimes it's just, developmental, right? Imperforate anus, hypospadias and epispadias, and bladder exstrophy. These are some of the ones to kind of focus on when you're reviewing the congenital conditions. Neural tube defects, normally occurs between the 17th and 30th day of gestation. spina bifida, meningoceal, myelomeningocele. It could be related to a Celtic ancestry. Again, local acid intake is the most common. Cleft lip and palate. The newborn can have a cleft lip and cleft palate, or just a cleft lip. It's the most common craniofacial birth defect. Often it may need surgical repair between 6 and 12 weeks. Cleft palate is typically between 6 months and 18 months. There'll be special ways of feeding these infants or an increased risk for aspiration. There are special bottles and nipples that can be used to kind of help promote and promote intake, oral intake, and then prevent aspiration. So with TEF, esophageal atresia and tracheoesophageal fistula. So your nursing assessment, you may see hydramnios during the maternal history. But on the newborn itself, you may see a copious frothy bubbling of mucus and drooling, and then abdominal distension. These infants may have coughing, choking, and cyanotic episodes. What it is it's a disruption between the esophagus and the trachea during the embryonic development. So it can lead to them having problems swallowing. They could be aspirating what they're intaking. So we want to make sure that they're going to be NPO. We're going to keep them their head elevated. IV hydration, oxygen if needed. Typically, it's a surgical procedure. Depending on what type they have, there's different types of TEFs. Post-op, they'll be on TP and antibiotics, and then they'll slowly resume oral feedings within 1 week. Omphalocele and gastroesthesis. So omphalocele is an umbilical ring defect. So the abdominal contents are coming through basically where the umbilicus is. Gastroesthesis is a herniation of the abdominal contents through abdominal wall defect. So there's no perinatal sac. So omphalocele, everything's contained in a nice sac. Gastroesthesis, there's no sac. So you want to make sure that you assess, is there a sac, is there not a sac, right? If the contents have no sac, keeping them wet and basically kind of sterile and moist is a priority. Making sure that they're maintaining their temperature. You want to make sure that whatever is protruding through the abdominal wall is not going to be harmed, right? So this is a surgical emergency. You want to make sure you are doing everything you can to prevent infection. Yeah, so if you see this in any of these two in Bakersfield, they will be transferred out. Imperfect anus. So again, doing your newborn assessment, you always want to make sure that you can see the anus, that it's visible and patent, right? It's an absence of an anal opening. There's no passage of meconium. Might be signs and symptoms of intestinal obstruction. So they'll have a distended abdomen. They may even have, feeding intolerance. It's all depending on how much they're eating, if they're eating. Typically, this is caught right at delivery. And again, it's a surgical emergency as well.
I'm sorry, but if this is closed while they're in utero, how is this not, is it closed in utero? Right? So how can it not be wouldn't there be problems that would be noticeable? How are they releasing waste? Is the mom not is she dehydrated? What's happening?
So
there's no sign while it's in utero that their anus is closed.
Right. Sometimes they can see it, sometimes they can't. But again, the fetus is not stooling in utero, right? So they are urinating.
They're just peeing.
Yes, they're not. The stomach is sterile until they're born. And so they're not actually passing anything through the GI tract. It's all urine waste in utero.
Okay.
For bladder extrophy, the bladder is protruding through the abdominal wall. Sometimes this can happen in the front of the newborn. Sometimes I've seen it once where it's bladder is coming through the backside of the newborn. It all depends on where the congenital defect happened during development. Typically, the bladder will be boys that have epispadias, meaning that so the penis where the urethra is, so it can be on top instead of at the end of the penis. Typically, they'll do bladder closure within 48 hours of birth, and then again, reconstructive surgery 2 or 3 years of life. Making sure that the area is covered with a sterile, clear, non-adherent dressing, irrigating the surface with sterile saline twice a day, and then they'll also be on antibiotics. Okay, so when you're reviewing this chapter, I've listed some topics here to make sure that you go back and review. When you get to the hyperbilirubinemia, make sure you have a clear distinction and understanding of pathological versus physiological. And then the bolded items for the congenital conditions, anything bolded on the slides, make sure you go back and you read the assessment and interventions for those. Okay. All right. Are there any questions?
Professor, would you be able to give us access to the full PowerPoint because we only had until slide number 30?
Again? Oh my goodness. Okay, nobody told me. All right, so I will I will re-upload. I'll just upload my PowerPoint. I won't even make it a PDF. And that way you'll have access to the Billy Tool link. Okay, yep, I apologize. I don't know if it was the new Moodle platform or what happened, but yeah, I'll upload that. Any other questions or concerns?
Where did you say to find like the stuff to focus on?
That last slide has topics to review, right? So it's certain topics listed there, and then anything really that has any bolded item on the slides itself throughout the PowerPoint. Okay. All right, so you have 3 chapters to do in Prep U, and then you'll have your exam 3 next week. So if you have questions while you're studying over the weekend or the rest of this week, text me or email me and let me know. And I will respond as soon as possible. Okay. But exam 3 is chapters 5, 19, 20, 23, and 24. Okay. All right. Enjoy the rest of your day. I'll hang back a little bit in case there's any other questions or anybody wants to talk to me about anything else. But I will see you guys all next week.
Thank you. Bye-bye.